I will call the roll. I'll start with you, Vice President Guillermo,
Present.
President Green,
Present.
and Commissioner Chow.
Present.
Thank you so much. Welcome, everyone. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Item 2 is the approval of the minutes of January 12th. Would you like me to call the items?
Yeah.
Okay. January 12th, 2026.
Okay, Commissioners, you have the final set of minutes before you. Can I have a motion to approve?
So moved.
Okay, all those in favor? Aye.
Oh, actually, let's see.
I'm sorry.
That's
public
all right. I
comment.
don't think there's public comment. Are there any public comment on the minutes in the room? I see no hands, and I see no hands remotely, so please continue with the
Okay.
vote.
Is there one?
I'm sorry, would you like to make comment on the minutes? Oh, yeah, come on up.
I complained last time about a Kaiser patient that didn't get in to Laguna Honda. She had been rolled out to a basically not a great nursing home in Millbrae. And I was given help by Laguna Honda administration, and she is now on the waiting list. She's been accepted. She just has to disenroll from Kaiser. And so it's a happy story. This is a retired school teacher who's poor as a church mouse. And, but she was contracted with Kaiser, who rolled her out to a not very good nursing home. And now she'll be near her 78-year-old sister and her 80-year-old brother in San Francisco, so they don't have to drive to see her. Thank you very much.
Thank you for the good news.
Thank you. Thank you. Okay, now, all those in favor?
Aye.
All right, thank you so much. We can move on to item 3, general public comment. Any general public comment in the room? All right, I didn't see the hand, and look online. I do not see any hands.
Okay,
So we can
Move
move
on.
on to item 4, the executive team report. Second. Okay.
Ready?
Yes. Please just let me know when to go to the next slide.
Okay, will do. Okay, good evenings, commissioners. My name is Diltar Sidhu, CEO for Laguna Honda. Here to present our exec report. And start with slide 1, Mark. So before I actually jump into the presentation, I just wanted to provide a quick update regarding the DON candidates, and I just wanted to share, as I mentioned last time, currently we are doing some follow-up on their previous employment before we extend any offers, and I just wanted to share that. So once we do have candidates, then we will share that information here in the JCC, hopefully by next JCC. So I just wanted to provide that quick update. In the presentation, I wanted to highlight, we just wrapped up our HSAG survey, which started on January 2026, and completed on January 30th. This was the first mock survey for this year, which included both health and safety and fire life safety components. As always, there will be a statement of deficiencies, 2567, that we will be getting from HSAG, and we will respond based on CMS guidelines within 10 days with a plan of correction. And that will be shared through our PIPS process as before. Just wanted to share some positive feedback that we received from our mock surveyors. As they mentioned during a resident council meeting, our residents expressed that they're happy about the care that they're receiving at Laguna Honda, and they were very talkative and supportive of the staff. I think this really speaks to the care that's being provided at Laguna Honda. I wanted to share this. Also, some general comments about cleanliness of smoking area compared to their past visits, overall infection control practices, where our hand hygiene, they only observe, I believe, one instance of somebody may not be using the sanitizer, but overall, I think the practice was really good. Our kitchen had a lot of improvements to the floor, and the freezer that was in question for quite some time was finally online. So they just wanted to share that good feedback with us. Race and pass. As you know, in the past surveys, we were dinged on staff not being aware of fire life safety protocols. And with their feedback, interviewing a lot of staff, especially our fire life safety surveyor, he likes to trick our staff as well to make sure that they actually understand the procedure. They were very happy with the response they received from the staff. And overall, positive feedback and the facility's readiness for a survey. So I wanted to share that update with you all. Next slide. In support of our culture change initiative at Laguna Honda, we launched nursing councils in January of this year. We're excited to have the space for our nursing staff to share their perspective, their challenges, their feedback, and the ideas to improve Laguna Honda. So just wanted to provide this update that this was an exciting time. I've been at Laguna Honda almost 3 years. I think this is the first time we have had these in quite some time. It's also a great venue for our leadership to provide updates and any information with the staff so the staff feels heard, and also getting the information from the leadership as well. This is an open communication with the staff and signals a change from the past, and also makes the staff feel inclusive in shaping Laguna Honda's future. So I really appreciate our amazing staff and the work they do every day, and looking forward to these conversations and positive impact on the council that council will bring to Laguna Honda. Next slide. So Laguna Honda Care Experience team has been continuing their community engagement work. This is also kind of in line with our culture change, making sure that we celebrate our staff and residents alike. So working with the Black History and Lunar New Year committees, as well as the Activity Therapy and Food and Nutrition Services Department, the month of February has many opportunities for staff and residents to come together to learn and celebrate. Some of the Black History Month events included Unity March, History Trivia, a Poetry Slam, and a performance by a Georgia Blues Band. For part of our Lunar New Year, we have activities planned such as making paper lanterns, lion dances, and the dream flying musics and other performances. This is just a way to highlight our diversity and celebrate the staff and our residents alike, which really kind of makes the whole place lively. So just wanted to provide those updates for exec report. Next slide, Mark. Next slide. Yes. So in this slide, back to admission update. As you know, we have been routinely providing admission update to keep this our JCC informed. So as you could see, we did admit about 30 residents in January, little slowdown from December. Some of that was expected. As you know, we were working through our list that we had with the waiting list, and we had exhausted that waiting list mostly in December. So we did expect some slowdown in January, but nevertheless, it was a strong month. We admitted about 30 new patients, as you could see, and our census continues to grow. Next slide. So our admission planning, we continue to expand South 5, slowly making sure that we are able to staff. So we were able to staff to be able to reach up to census 40. Currently, we're sitting at 37. And as we go up in census, we will be opening the rest of the 9 or so beds to make sure that we can reach full census in South 5. We're also continuing to engage with other partners to ensure that we can get referrals for our North Mez, which is a dementia unit. As you could see, that's where bulk of the beds are as well. So we continue to work with our WIPIC and other community partners to make sure that we can continue to receive referrals that are appropriate for North Mezzanine. Next slide. And this slide kind of provides an overall view to different types of beds that we have available. As you could see, we have quite a few in care dementia unit, some in short-term rehab, and then rest in long-term care, which mostly, like I said, the bulk of that is in South 5, and then the remainder, about 1 or 2 beds per unit in most of the other long-term care units. Also quickly wanted to highlight, we do have few residents on waiting list, which are waiting for specialty units. A bunch of those, I believe 5 or 6 referrals are specifically for our North 5, which is our Asian focus unit. We've been working with those residents as the beds are becoming available. So most of the waiting list is really people looking for specific type of beds. We have really exhausted through the rest of the referrals to make sure that we can admit anybody that we can admit. As I shared earlier, we have continued to make strides in the census. We are currently sitting around 590. And at this rate, I think we will be full before the end of the fiscal year, which our goal is to make sure that we can continue to grow census safely, making sure that we are supporting the staff as well as our community and the residents as well. Next slide, you could see this is our information on how fast we are accepting the referrals from Zuckerberg. It's well under 4 days currently. And the next slide kind of shows similar data for, if you can jump to next slide, Mark. This is for all referrals outside of Zuckerberg as well, and we're sitting around average of 4 days as well. So we continue to make improvements as far as how fast we are reviewing and approving the referrals, and also looking for ways to continue to be better at that as well. Next, can you jump to next slide? And this slide is trending of the data as far as how many referrals we're getting from our top referral sources, which is group 3, 4, and 5. And our denial rate, as you could see, we continue to see a decline in the denial rate, which was about quarter of the referrals, 27% in our latest in January. There was a slight decline in overall referrals in January, as you could see, but our denial rate continues to remain low, and the main reason is really a lot of referrals are not appropriate for Laguna Honda, and they're appropriate for lower level of care, as you could see on this slide as well. Just a slide that's showing overall number of referrals from our different priority groups. As you could see, we are receiving a lot of referrals from group 5, which is other non-SNF SFHN medical facilities. We continue to see a strong demand for beds from outside of Zuckerberg as well. Okay, I think this is the end of the presentation. I have some slides on follow-up from last time, which was regarding our plan for improving quality measures, and I'm going to ask our interim DO and Maria Antoak to share that with you. Thank you.
Good afternoon, Commissioners. Maria Antoak, Interim Director of Nursing for Laguna Honda. As shared in the last JCC, we wanted to share a high-level plan for Laguna Honda to improve our quality measures, which are the true metrics of care being provided to our residents. So before I move on, I just wanted to share, the definition for short stay and long stay measures. So for short stay quality measures, this is to assess nursing home care for residents staying 100 days or less, focusing on rehabilitation, post-acute care, and safe timely discharges, often using claims data. For our long stay measures, these track chronic care for residents over 100 days, focusing on functional maintenance, physical decline prevention, and quality of life. So the short stay measures, that we will be working on, and I'll share that in the second slide. So per our LHH Care Compare 5-star provider rating report for November and December of 2025, our long stay quality measures remain at 5. However, our short stay quality measures are still at 1 star, making the overall quality measure rating at a 3-star, same as what we reported last JCC. So our nursing leadership had put together a plan on how we will work on improving our quality measures to improve the quality of care being delivered to our residents. So following a comprehensive review of our data, we actually had identified 2 short stay quality measures and 2 long stay quality measures to prioritize for improvement. So we actually started our A3 already. So for our short stay quality measure, which is showing in the slide right now. So we're focusing on 2 critical priorities. One is minimizing the initiation of antipsychotic medications. And also the second priority is reducing the incidence of new or worsened pressure injuries. For us to be able to achieve these goals, we will implement a proactive admission protocol that ensures comprehensive documentation of residents receiving antipsychotic medications, including psychotropic consent forms, and also accurate pressure injury assessment and coding. These measures are designed to strengthen clinical oversight and improve our resident outcomes. Next slide, please. For our long stay quality measures, Laguna Honda will be prioritizing 2 critical areas. So one of it is also reducing antipsychotic medication utilization and lowering our rehospitalization rates. So these initiatives align with our overarching goal of enhancing resident outcomes and optimizing care delivery. For us to be able to achieve these objectives, we are implementing a targeted strategy that strengthens clinical assessments, elevates documentation standards, and leverages a robust admissions dashboard for proactive care management. And so some of the things that we're working on are, so one is a revamped psychotropic committee. So this will be expanded and formalized through IDT, which are in collaboration with different teams, nursing, pharmacy, physician, and quality management, to review all residents on antipsychotic medications and to provide evidence-based recommendations for appropriate use, as well as gradual dose reductions and other non-pharmacological intervention. So the second initiative that we're working on is early detection and assessment of residents with change in condition so that we could do a prompt follow-up while they're at Laguna Honda and provide treatment as needed, decreasing the need for acute hospitalization. So those are the measures that we've started working on, and as what I have shared, we've started on A3 and we will be working on all of these areas to ensure that we have excellent quality care for our residents. So, thank you.
Thank you. And if there's any questions from the commissioners, we're happy to answer those. Thank you.
Okay, is there public comment?
Is there public comment in the room on this item? Can't see any hands. Do I see any hands? I don't see any
I
hands.
don't see any hands.
Do see a hand remotely. Mr. Menshaw, are you there?
I am a code AA Mark.
Please begin.
Thank you.
Once again, the state of the hospital, slide number 17, makes no sense. The end of the month census line reports there was a net increase of 18 residents, from 572 at the end of December to 590 at the end of January. Then it claims there were 30 admissions in January. and a net loss of 16 residents, involving 4 planned discharges, 1 unplanned discharge, and 11 patient expirations. Subtracting the net loss of 16 from the 30 admissions translates to there was a net change of just 14, not the net increase of 18 residents reported on the end-of-month census row. Why does this math not add up month after month after month? And none of you health commissioners ever questioned this report's mathematical veracity? Has something with basic math changed that I should go back to school and take a refresher course? Its alarming slide number 17 reports the current quality state of short-stay nursing care is at just 1 star. That's not a good messaging statistic to attract admissions for short-term skilled nursing rehabilitation services. This must be rectified rapidly. Thank you.
That ends public comment for this item.
Okay, thank you. Are there any additional comments or questions from, yes, Commissioner Green?
Yes, well, thank you for the presentation. I do have one about the future math. So as I look at this, you have anywhere from as few as 4 to as many as 20 aggregate number of individuals who leave Laguna Honda on any given month. So given the uptick in interest, especially among that, group 5 and so forth, and some of the things that public comment has said about people needing to get in and needing to expand our reach to other San Franciscans, if, we're admitting, 2019, 37, 30 each month in the last 4 months, and yet there'll be a point where you reach capacity and you don't have as many people leaving, how will that be managed? In other words, do you feel that the individuals being admitted now may have a higher turnover, may be, discharged sooner? I mean, we're almost getting to this point where we've got to think through maybe not having enough capacity. So I'm wondering how you all are thinking about that.
So as we become closer to full census, we are continuing to make sure that our discharge process is robust. So that way we can continue to serve the needs of the residents who are coming in for short-term stay. So we will definitely have a number of long-term residents who are here at Laguna Honda, and then we will have a number of short-term beds where we can continue to make sure that we can serve the needs of the residents who need short-term rehabilitation or other care, and then continue to discharge them back to the community. So we'll really have to be robust on our discharge process, which we continue to improve and focus on as we are getting close to full census.
And then it's been a long time since we've heard about the residents that remain at Laguna but don't qualify for SNF care. And I'm wondering if there is any update. I think at one point there were 29 or something. Where are we on that? I mean, how is it? Because now it becomes even more critical as you reach that 630 number to have a limited number of individuals who no longer qualify.
So actually, a lot of that list that you're talking about, the 29 residents, really came through as we were going through the closure process, and CMS was looking at the residents who may not have been appropriate. We do have a process to look at all the residents who are at Laguna Honda to ensure that they meet either skilled or custodial level of care. We are in the process of developing a different discharge dashboard to reflect more the reality of a normal functioning skilled nursing facility, that once that dashboard is up and running, you will probably be seeing that through the PIPS process. But we have, I can look at the exact numbers, but most of those residents actually, we had gone through, and any residents who were independent were discharged to the community. And a lot of the rest of the residents were really complex residents who actually meet the custodial level of care, and they're actually all being covered through their SNF, their health plan as well for custodial care, because they do meet the criteria to be at Laguna Honda. But nevertheless, we continue to screen the residents quarterly to ensure that resident who can be migrated or who can be discharged and integrated back into the community, that we continue to look at those opportunities and work with those residents on the discharge. But I'm happy to get you the numbers. I believe we did that last time. I don't have them in front of me, but I think that list, we have gone through the list. There may be 1 or 2 residents who still remain, but most of them have either been discharged, or some actually their level of care have increased and they continue to meet the criteria to be at Laguna Honda.
Well, I appreciate that, and it would be helpful to get those reports and also to hear your thinking, letting us know how you will plan for, a future where potentially you could have not enough beds for the people who might need them. Thank you.
Thank you.
Yes, Commissioner Chow.
Thank you. I'm wondering, since I'll just piggyback on the additional beds or the need for beds, where are we in terms of our potential of getting the 3 bedrooms back?
So as you know, there was a decision made at the time that since the waiver was denied, that we will not pursue that waiver at this time. We're happy to have those conversations when the time arises, whether we would go back and pursue that waiver, but it was initially denied by CMS, and then DPH decided that we will not be pursuing that waiver at this time.
Okay, because I think related to President Green's comments, if we are at a capacity, and I'm not saying it's going to be a year or 2 from now, but we shouldn't forget that the way that we left it, right, with the feds, we said that we have the ability to come back and really talk to you about this. So I think one of the potential solutions to the question of not enough beds for our population and the evidence and the information coming in really sort of begins to support the need for more beds in San Francisco, that time could be used as advantage when the right time comes in terms of applying for it. So I just want us to remember that there is there's still another route to add beds that would help our residents. I had about 3 questions. Oh, and I want to thank you in terms of the completeness, in terms of the data that we are getting now today. I think gives us a clearer picture of admissions and also what the census is. I would like to take, if we could, the public testimony from Mr. Minoth Shaw and try to understand what numbers he's really talking about and which ones we are not following. I mean, what we're following is end of month census, which is really kind of the key number at the end. But I think that, and I couldn't find slide 17, so I'm not quite sure what he was referring to. But I do think for several months he's been speaking of the data not matching. So if we can get an explanation as to, we might be looking at different types of data or what it would be helpful to us, but if that's possible.
Yes, definitely. So I just want to highlight on the slide that's in question. We're sharing certain numbers on there as far as admissions, expirations, and discharges, but that slide does not paint an entire picture. There's residents who go to the hospital and their bed holds expire and they may not have come back within that month. Those are not being shared on that slide. So there's some data elements which are missing from the slide, so the numbers don't add up. But we could definitely look at ways where we can add other columns to it so you could see the different categories and then the numbers would add up. So I'm happy to look at the slide and see how we can make it so the numbers can look, that you can actually add them up and then they add up to the total census with how many expiration, discharges, and admissions.
Correct. I will leave that to you. I think all I was saying was we'd like to understand which numbers the public is looking at, and not that that's how this needs to be, regularly reported by adding more columns to our data. If what we're following is what's the end of month census, which is sort of the key as to, what the census is, because we know every day there are people who are away or for another reason on an LOA that we're looking for or whatever it is, that you have not closed out the census. But okay, I had 2 questions before this all arose. One was on the nursing council, which I think sounds like a very good idea. But in their charter, is there a membership, or it's only charge nurses, or it's an elected group of people that represent the nurses? I mean, how do, I guess, who is really there? And what will be their agenda for the future?
Commissioner Chow, so we've started with the Charge Nurse Council. So all the charge nurses, every shift has the opportunity to attend our council. And for the CNAs, there's one representative per unit. And for so charge nurse, and then for the other, like for RNs and LVNs, there's also an ask to start a council so that, they also have their own group. So I'll be, discussing that if, there's a possibility for us so that there's also representative from other areas.
So you've got several different groups, or?
Yes, several different groups.
Okay, so it's not just one nursing council.
Yeah, no.
Oh, okay, so there are other groups that are similar. This is
Correct.
the charge nurse that you
Yes.
described, and you're hoping to get the other nurses into.
Yes, because they're also interested in starting their own council. I guess because they heard that, like the staff who attended the councils last month, they were very excited about it. They were very involved in creating their agendas and sharing with us what they wanted to discuss. So now there's an ask to start another one for just the RNs and LVNs.
Great. So maybe within a quarter, we could hear how this is progressing and what type of feedback you're getting and how you are setting your agendas. It sounds like a very good way to gain participation and information
Yeah.
from the front line.
Yes. Yes.
So-
Yes. Thank you.
All right, thank you. Then I had another question in regards to you're working on the short term and the, short stay and long stay. Wanted to know exactly how we could track how you're coming along, or is that being put into some sort of report that we're going to be seeing? Because it sounds like you are working on those areas that you've now defined. So will this become part of the regular quality reports or what?
So there is an A3 being developed that will be shared as part of our copy process. So you will have more detailed information through the reports that you get as part of the copy.
Okay, great. Thank you. Those are my questions.
Okay, any other questions? Okay, thank you for your report. Moving
Thank
on.
you.
Move on. Thank you. Item 5 is Laguna Honda Hospital Commercial Payer Contracting Context and Opportunities. And I'll pull up the press.
Good afternoon, Commissioners. Tangerine Brigham with the San Francisco Health Network. Mark, would you mind? Thank you so much.
Just let me know when to go to the next ones.
Great. Diltar, I'm taller than you. All right, I thought I would give an overview at the request of the commission and public interest about the contracting opportunities that exist with Laguna Honda Hospital. So in terms of services, broadly, long-term care, custodial, as you're aware of, skilled nursing, short-term care, acute care, both general and rehab, and then rehabilitation services. You heard Diltar mention a moment ago the current capacity and the census, and his belief that the facility will be at full capacity before the end of this fiscal year, and we've got 11 acute care beds. Next slide, please. When we think about the patient population, one of the things that occurred at Laguna and with, I believe, input from the commission outlining the priority groups for the facility. So there are 5 here, and I actually just have this to refresh everyone to make sure that we're all on the same page. One, as a result of the decertification, the first priority was ensuring that any individual who was transitioned to another facility had the ability and the opportunity to come back to Laguna Honda Hospital. That's our first priority. Our second priority are serving San Franciscans who are not in medical settings. Maybe they're in their homes. Their health conditions have changed. They now need skilled nursing care. And so that's our second priority. Our third, as you know, we are a broad delivery system. So within the network, it's not just skilled nursing and rehabilitation services. We have an acute care facility, ambulatory care services, and patient flow is very important to us. Ensuring that people are in the right place at the right time in the right clinical setting. And so making sure that we have opportunities when someone is in acute care who needs to be transitioned into a more appropriate level of care, and they meet the criteria for Laguna Honda, that we're able to do so. So that's our third priority. Our fourth priority, San Franciscans who are in other facilities. They're receiving SNF or rehabilitation services, and they want to go to Laguna. And then finally, patients who are at non-network medical facilities. So you can see from here, hopefully, that Laguna Honda is a facility for San Franciscans. It is not just a facility for the network. Next slide, please. So why enter into a commercial contract, or any contract for that matter? One is if you've got excess clinical capacity, and you just heard the conversation a moment ago. We may not be at that state for very much longer, but certainly if there is a need to increase patient volume, that is a reason to contract out. Secondly, there's a demand for one's service. You can have the clinical capacity, but no one's interested in the product that you're selling. It's very difficult to enter into those contracts. Thirdly, we might want to do it if we're serving a commercial population, but it's ad hoc, what we call letters of agreement. They are one-offs where we have an agreement to serve one particular patient, but we don't have an agreement that's broader to serve more patients with that insurer. Fourth, we can meet the contractual requirements. Sometimes those requirements are onerous and burdensome, and it may not be worth contracting. So you want to make sure that you're actually able to meet all the contractual requirements, be it either access, quality of care, care coordination, authorization, et cetera. Diversifying one's payer mix. No one wants to have all their eggs in one basket, as they say. And so diversifying the payer mix is another way of expanding the patient base and certainly helping us sustain our revenue levels. We want to make sure that whatever reimbursement we receive exceeds the cost. And the cost is not just the cost of services, but the cost of actually providing those services and the administrative component of that. And finally, you enter into a commercial contract if you've got a good brand. And so that's really important. Next slide, please. So our payer landscape, the first is Medi-Cal, both fee-for-service and managed care. I'm not going to go into that in detail. That's in the appendix if you're interested in more detail about that. Certainly there's Medicare. We'll talk a little bit about that, both traditional and Advantage. Commercial, that be it either an EPO, an HMO, or a PPO. And then there is, in fact, long-term care insurance. Next slide, please. So on the Medicare side, I know you know this well, but this is just for the general public. Long-term care or custodial care is not covered under Medicare, either traditional or Advantage, which is essentially an HMO for the Medicare population. Short-term care is covered. On the traditional side, you can see that it's covered for up to 100 days under Part A, and there is, depending upon the number of days that are needed for the patient, either it is covered entirely by Medicare, or after the 21st day, it's a combination of Medicare and then a copay that the patient pays, or their family. And then Medicare Advantage, I think it's really important to note that the authorization and the utilization process for Medicare Advantage is very different from traditional Medicare. And traditional Medicare, the SNF determines what that need is for short-term care. When it comes to Medicare Advantage, because it is an HMO, it does go through the utilization management process of that HMO. Also up to 100 days. Typical stay is generally anywhere from 3 to 4 weeks. And so for most patients, Medicare does cover that cost because it's within that 20-day period for most. Next slide, please. Going to commercials. So we do serve, and I believe you heard earlier from the public that we have individuals from who have Kaiser as their, have had Kaiser at their health plan. We do have a demand for long-term care from Kaiser. Currently, we have 12 patients. We have 4 you can see here on the wait list for specialized units. We really want to go from having a letter of agreement to really contracting with Kaiser to reduce the burden. Most of these are custodial individuals. What generally happens, because we don't have a full contract, when that patient needs specialty care, they have to actually be transported to Kaiser for those kinds of services. There's an authorization process. I keep hitting this. There's an authorization process for that. And we would like to minimize that and make sure that all the care is provided to the extent possible within the network. Then we know that there is some interest from members of the public around, can Laguna Honda be offered in health plans for city employees and retirees? I had the opportunity to speak with the lead skilled contractor for skilled nursing facilities at Blue Shield. And to get a sense of their interest in contracting either, for city employees just for this facility, which they do not do. They generally contract for an entire region. So it would be for example, the city and county of San Francisco. I'll continue my conversations with that entity. They've indicated from their perspective that they have sufficient access, adequate access. Now, that can be defined differently depending upon the hat you wear. That could be for them, members having access in not only San Francisco, but the outlying counties of San Francisco. So at this point, they're certainly, I think, welcome and believe in choice and believe in options, and more options, I think, they would appreciate. But we will continue to have conversations about whether or not Laguna Honda is a appropriate addition to their network. So what are the considerations and the opportunities? So in terms of the considerations, I think the biggest one is what we call crowd out. And you see it here. And in this context, when you have a limited supply, in the case of the supply is the number of beds, serving individuals with more commercial coverage may displace individuals who are on Medi-Cal, or individuals who are uninsured for whom have historically used the facility. And so it's really important to go back to the principles and the priority populations that I described earlier in this presentation to ensure that the facility is available for those individuals moving forward. And then obviously, you're not interested in increasing your administrative burden when you're contracting out. In terms of opportunities, certainly it affords us the ability to ensure that as patients are transitioning from one level of care or one insurance option to another, that we're able to serve them. So for example, we're particularly interested as individuals migrate from Medi-Cal into what is the equivalent of an HMO for dual eligibles called DSNP, that we're able to serve them in Laguna Honda if they need skilled nursing care. We want to be available to them as they age into and have the option to take Medicare Advantage, which for the Medi-Cal population is called the Duals program. Next slide. The other area I thought I would talk about beyond SNF is acute rehab. We have 11 acute care beds at Laguna Honda, and 5 of those are designated for acute rehab patients. Our average daily census is 3.4 acute care patients. Of that 3.4, 1.2 on average for the last 12 months are individuals on the acute rehab. That's embedded in that 3.4 number that you see there. We are assessing the billing opportunities based on some guidance that we've received from CMS, essentially, in order to maximize revenue for an acute rehab, you have to have a certain number of beds. And hopefully you've seen the response that I provided, but we would have to have at least 10 acute care beds for every 1 general acute care beds for every 1 acute rehab to be able to bill the acute rehab at that increased rate. We do not have 10 acute general beds. You can see here we have 6. And one of the things we're looking at is whether or not necessarily increasing the number of beds, staying with 11, but perhaps having 1 designated for acute rehab, given the fact that our census is around 1 on average, and then the other 10 general that would enable us to bill in accordance with our current understanding of the regulatory guidelines. We are still exploring that, but that gives a sense of where we are with that. In the interim, to ensure that we do not run afoul and result in an audit, we are billing all of those days as general acute, as opposed to any of them as acute rehab. The next slide, my error here, that should just read rehabilitation services as opposed to outpatient rehabilitation services. My apologies there, because the information on this slide just really is a general summary of all the services and programs that we have at Laguna Honda, rehab services. We have occupational therapy, physical therapy, speech therapy. It is demand and volume driven. You can see the referral sources, and currently the supply and demand is generally balanced. So it's not something that we would be able to say, for example, sell or put on the market without an increase in our clinical capacity to be able to do so. So going to recommendations, we really want to, I'm sorry, next slide, thanks, Mark. We want to preserve our Laguna Honda capacity for our priority populations. I think we certainly want to pursue commercial contracting with Kaiser to help reduce the administrative burden and the clinical authorization process that goes along with that. Obviously, we would do that only if we undertake a financial analysis and it is worthwhile to do so. We will sort of assess the additional ability of contracting for other health plans for employees and retirees. That would also require a financial analysis. And as I mentioned a moment ago, we will review the CMS requirements related to acute rehab unit billing. And I believe, yeah. Do you have any questions of me?
Thank you, Chandra. It was very informative and helpful presentation, and see if there's any first public comment.
And there is in the room and remote.
Okay.
So we can start with Janet Fowler, who turned in a slip. Oh, Dr. Palmer, would you like to go for whoever? I just got a slip, so I'm using that. Remember, wait till you're at the microphone, please.
Thank you. One of the things that I think I understand the worry that we want to preserve beds for those who are already in the public system, but we are the public nursing home for San Francisco, and Laguna Honda is. And there's a lot of low-income elderly retirees who are close, if not at the Medi-Cal level, when they are hospitalized and end up in skilled nursing rehab. And the thing that's keeping them from Laguna Honda is not that they're not at the Medi-Cal level, it's that they're enrolled in Kaiser or Blue Shield or one of these. And so they're told they can only go to facilities that Kaiser and Blue Shield contracts with. And I think in the discussion with the Blue Shield contractor that he is wrong. Why are people being sent out of county if Blue Shield has adequate nursing home beds? And anyway, Janet Fowler will follow me with the story of her friend who died much sooner than she would have if Blue Shield had done a decent job. So I really think we have to look at also disenrollment not being a bad word if that is going to keep people in the place that's safe for them. And for most elderly people with elderly families, staying in county and close to home is the safe place where your significant others can monitor and oversee your care. And for many medically complex people, Laguna Honda is really the only safe place because of the quality of the staffing and the care and the doctors that live with the patients. So anyway, I wrote this all down so Mark can include it in the minutes, but thank you.
Thank you. And Ms. Fowler, please come up.
Thank you. Yeah, yes, I would like to tell you a little bit about my friend BJ, who I went to pick her up for a doctor appointment at her home. Her home I hadn't been into until very recent to that, and it was really uninhabitable, and she was living really in a very sad situation. Am I okay on the mic?
It's better to do it like here, and you've got 3 minutes just to know
Okay.
the temp of your phone.
So I found her in such a weak condition, she couldn't stand up, and I called 911 and had her taken to the hospital. It was on the eve of the Labor Day weekend, and her condition was so bad that I was sure that she would be in acute care for a while. But it turned out that, now I'm going to go on script and just finish reading. I want to say that she was a Blue Shield city retiree on Blue Shield. And I had checked to see if there were beds available. The website at Laguna Honda said there were beds available, and I hoped she would go there because I knew that's what she needed. But after 2 days at CPMC, social worker announced a discharge to Babe Marina SNF in Oakland. She had no family here, only friends. She was threatened with the large bills. She agreed to go, and we had no other options. At Bay Marina for 2 weeks, BJ was neglected. She became bedbound, dehydrated, and close to death. I made staff at Bay Marina call 911. At an Oakland hospital, our appeals to prevent discharge back to Bay Marina were denied by Blue Shield. Discontinuation of hospital treatments before her discharge resulted in shock. My friend BJ died after 22 days at Alta Bates. She suffered terribly. She suffered terribly in the 2 weeks in Oakland. We wanted so much to keep her. I thought that Laguna Honda would be a safe place where her friends could keep an eye on her. She died, and it wouldn't have happened had she been at Laguna Honda Hospital.
Thank you. Is there any other public comment in the room? All right, let me check online. Yes, give me 1 second. Mr. Minetshaw asked me to show a slide. Let me pull up the slide. Okay, thank you. Okay, Mr. Minetshaw, I'm going to unmute you. The slide is showing.
No, this slide is for item 6, not this item, Mark.
Oh, I apologize. Well, I'll take the slide down. You just begin. I apologize for that. Please begin. Mr. Minetshaw?
I enter into on the slide. This is why I enter into a commercial payer contract. The last bullet point says when the brand reputation is high. I have not talked to my neighbor whose mother needs knee replacement and is going to need short-term rehab until she can safely walk upstairs in her building. I have not talked to them about Laguna Honda, but they are already trying to find an alternate place because they have heard about Laguna Honda's reputation. You believe that LHH has a good reputation for skilled nursing rehab is misplaced hope. On the slide for acute rehabilitation, Ms. Brigham mentioned that currently your billing is general acute and not acute rehab to Medicare. And I want to remind you, when I was secretary in the Rehab Services Department, as they were planning for the new hospital, Dr. Lisa Pasquale and Paul Carlisle had me massage their budget submission on a Form B where they were justifying having 15 acute rehab beds in the new rehab, and I kept telling them that other hospitals in San Francisco were not going to let that lucrative pot of money be taken away from them. And yet they pushed through that budget document D and got additional staffing for the new hospital, and you have never been able to fill even 5 or 6 of the acute rehab beds. That may be related to the lack of a reputation for services at Laguna Honda Hospital. You guys really need to work on all of this. And if you have excess staff,
All right, thank you.
Form
Time's
D,
up, Mr.
you
Minichov.
should
All right, that ends public comment for this item.
Okay, thank you. Are there additional questions or comments from the committee? Yes, Dr. Chow.
Thanks, Ms. Brigham, and thank you for coming back.
Thank you.
Because, again, because instead of Healthy San Francisco, maybe you can help us out here at Laguna. And I think this presentation is the first time I've gotten really good response to the questions that I've asked, which are in my case particularly trying to understand where we were with acute rehab. The public testimony sort of gave the very beginning of this. And the question is why, when we first started building Laguna, there was a desire to have a good rehab, acute rehab. So I think that we need to separate 2 issues here, which you have done. One is the track for acute rehab, and is it that we do have good acute rehab? If we don't, we can't sell it, of course. But if we do, as we were promised, and put in a big pool and everything, then in order to have all that we're doing, I think we need to assess, do we really have an acute rehab that is marketable, as you said? And then the whole issue of payer. But this is the first time that I think we have an opportunity to really do a in-depth study as to what is happening and why we only have 1.5 people at a time as a census over there. And I don't want to ignore that we have to be sure that we do have an acute rehab. We can't promise that. On the other hand, on the long-term care that you are then with the other segment and have discussed that we don't want to push out our 5 priorities, but the 5 priorities do include the rest of San Francisco. So I think it isn't that, obviously priority 1 is pretty well taken care of. There will not be people in the future that are within priority 1 because there's sort of a time limit essentially that there will be residents under that category, right, in the long-term future. So I do think that there's at least 2 issues that you've identified very well, and you've articulated that really it's important to deal with Kaiser for one thing. We know they have a very large block of people, and I think the testimony you've heard, or maybe we've seen, really says that San Franciscans, and we saw that on the trauma when we moved people out, really don't do well when they're not being supported by their environment, including their own families or friends. But I think that I think that you're giving Blue Cross, Blue Shield, almost a pass by saying it's sort of up to them if they want more options. I think we should be in a position where if this is a city contract and they want a city contract, patients of theirs that are within the county system really should be able to have this as an option. And it goes back to the fact that they are our city provider under our healthcare services, health service system, then that should include services that are inclusive here in San Francisco. And so I would encourage that while we're working with Kaiser, there's got to be more than just, it's a great option for you and you should add it in terms of our approach, but that it's really important for those and for the contract that gives you all these city employees, that you allow the city employees and their retirees to have the opportunity to be able to apply for Laguna if they qualify.
Thank you. We will certainly continue our conversations with Blue Shield. Absolutely.
So I'm wondering, as we're going along and we're finally opening this as a more transparent process for the needs that have arisen, let's say, how can we best get a update on what we're doing in terms of a timeline that you would feel comfortable with also?
Yeah, I think I indicated that we could come back to the Joint Commission in May.
And that would be fine.
Yeah.
I think up to the chair, of course.
No, that would be good to, if it could be sooner, that would be great, but let's aim for May
Yeah.
at this point. Yeah.
I might be.
Well, that's certainly better than the years we've been waiting. So really appreciate, once again, welcome back.
Yes, Commissioner Green.
Thank you.
Well, as always, thank you for your incredibly clear and informative presentations. You confirm everyone that comes from Kaiser is actually a San Francisco resident, because a lot of high-risk healthcare is done in San Francisco Kaiser for people who live in Marin and elsewhere. So they're all definitely San Franciscans.
That is a good question. It's my understanding, yes, but Albert, can you verify that for me? Thank you. For the commission.
Commission, good evening. Albert Lamb, Chief Medical Officer of Laguna Honda. Yes, the answer is yes. Our admission and eligibility department does look at place of residence and has to be in San Francisco to ensure that they meet our criteria to be a Laguna Honda admittee.
Thank you.
Thank you.
Thank you.
Yeah.
And, another question, do we have any sense for the number of retirees who are now on Blue Shield that might wish to get into Laguna? In other words, they may be in hospitals where they don't even approach Laguna because they already know that there could be so many administrative challenges to attempt admission that they won't even do it.
We do not have that information. I don't know that Blue Shield could share that information. First, they'd probably have to do a survey of their members to see for those who are nearing potential skilled nursing needs or at other skilled nursing facilities, whether or not they might want to come to Laguna. So that means the individual will have to answer that question. And then they couldn't tell, they would only give us a count if they were to do that. We wouldn't have that information. We could certainly ask them. They do have contracts with 11, I think, of the 15 skilled nursing facilities in San Francisco. Along with Laguna, there are 3 others for which they do not have contracts. I could see if they could give us a sense of sort of utilization, essentially, amongst their population. But that's just general. That doesn't specific to City and County of San Francisco employees.
But it might be really interesting to find out, if everyone who lives in San Francisco is being adequately placed in San Francisco, that would be really useful to know. And I guess the other question I have, how long is the city committed to having Blue Shield be their provider? Because it wasn't that many years ago that we used United Healthcare and it switched. I don't remember when it switched to Blue Shield. I obviously see a lot of retirees from the city, and I remember their cards changing a few years ago. But I mean, do we have negotiating power? Can we reach out to health plans other than Blue Shield to, and at what point would we have the opportunity to do so?
So in terms of the first question, I reached out to the COO, Ren Coolidge of the Health Services System, which is how I got the contact for Blue Shield. The city and county, goes through their own process of identifying insurers. I don't know the current contract, how long that is for. Generally, the contracts are anywhere from 2 to 3 years. And I can certainly find out how long that is. If in fact the city and county were to change their insurer, certainly we would approach them to see, could Laguna be part of the network for all skilled nursing facilities. In terms of us contracting sort of directly with an insurer, be it either Anthem or Aetna, we would go through the same process that we would go through with any commercial insurer. What's the market, what's the demand, what's our capacity, the financial analysis. They may or may not have any city employees. If we're sticking with city employees, you would be doing that if you really had a lot of excess capacity to sell and you wanted the patient volume.
Would they ever bifurcate the retirees on the MA that comes through Blue Shield with the commercial side for city employees? In other words, how much clout is there in terms of informing those who are negotiating on behalf of the city to bring the concerns about our retirees into focus and have that be a potential weighted component of the health plan they ultimately decide to partner with?
We can certainly have that conversation, start that conversation with the COO, Ren Coolidge, to determine sort of what is possible. Generally, insurers contract for regions. They don't contract for a specific facility. So, in this case, we would be asking Blue Shield, hey, in addition to the 11 skilled nursing facilities you have, for individuals that are just city and county employees, put in your network that Laguna Honda is only available for city and county employees. I mean, that's how it would appear in their network. And that, I think, we would have to determine whether or not that's something that they are interested in doing.
Well, I appreciate that. And I really would love to know when negotiations open again to reconsider Blue Shield as opposed to another carrier. I mean, so much is changing and so much is changing in MA. Maybe no one wants to do MA anymore. But it would be interesting to know kind of what that timeline is, especially given what's happening in all the cutbacks and that'll come in 2027.
Yeah, I will certainly reach out to Ms. Coolidge and get that information.
Great, thank you.
Okay, just to clarify then, in May, there are at least 3 things specifically that we would like an update on.
Yeah.
One is sort of the Kaiser contracting, Blue Shield negotiations, and the billing reimbursement for acute rehab. So, and then if there is anything else that the commissioners are interested in getting updated on, or if there are any other issues that come up between now and May, then we have an opportunity, I think, through the secretary to pass that on to Ms. Brigham, so that you can, in your update, provide that information.
Do our own capabilities in the in the acute rehab to make sure that we are current as to what is to be expected.
Okay.
To make sure that we're competitive.
Right, so that would probably be both part of your presentation informed by folks at, at the facility, right? Yeah, okay, so 4 things.
Okay.
Okay, again, appreciate the presentation. It was timely in its own way. And we look forward to the update.
Thank you.
All right, we can move on, excuse me, to item 6, senior affordable housing at Laguna Honda Hospital Campus. And I will pull up the presentation.
Good afternoon, Commissioners and Commission Secretary. Mark Primo, Capital Projects Oversight Advisor to DPH. And I think before I get into the agenda slide, Dr. Chow, I wanted to give more clarity to my role and what I'm going to be responsible for. It's going to be very similar to the UCSF research ground lease and MOU, where I partnered with Assistant Dean Dr. Sue Carlisle. And while I'm the liaison for DPH, I'll be supporting Deltar and his staff, who will really be the liaisons to that project since it's on site. So that's the distinguishment between like my role to help things, to make sure that there's no conflicts with either city policy or DPH policy in the terms and conditions, whether it's the MOU or the ground lease. And so let's see the next slide. So what we did is we wanted to give the JCC and the commissioners several looks at these documents. And that's why we've attached the full draft MOU as the appendix, because it's going to be coming back again at the March 9th meeting. And then we'll be heading into 2 meetings at the full commission on April 6th and April 20th. So we wanted to give you ample time to review it, see what your questions and concerns are. So the agenda is going to be the draft MOU, kind of highlighting the different roles and responsibilities. And it's a pre-development MOU, which means there'll probably be at least 1 and maybe 2 other MOUs that cover activities during construction, which are different than this pre-development. The draft parcel map is being worked on with city's Public Works Department and Mercy and their team. And then the logistics plan we've been working on, and we've included that, showing you the different stages of the project's evolution and what has to happen, the access to the sites, circulation paths, pedestrian and construction. And then lastly, but not least, is the report on the Woodside Gardens residential transportation access from, which will be presented by Sharon from Mercy. So the next slide. So as I said, this is a pre-development MOU. We've given it 4 years, and I doubt whether it's going to take that much time to get this approved, but we didn't want to do it again. It's going to cover, and it defines the project. It's only going to be 100% affordable senior housing, about 158 units, with a goal of reserving or allocating 25% of the units, roughly around 39, to the residents or other parts of DPH. There's roles and responsibilities are included in here, broken down by the 3 parties, DPH, MOHCD, and Mercy. And it also will have a schedule, milestones, and benchmarks. Next slide, Laura. So some of the duties for DPH that are happening now are some biweekly meetings, project meetings with Mark Morowitz, who's volunteered to be a part of it, which has been extremely helpful. It's the 3 parties and then anyone else who we need to bring in, like possibly Department of Real Estate on an as-needed basis. So we have these meetings, and we have also subsets of meetings that deal with transportation, logistics on site, and the design. So these are some of the roles: participating gives feedback around design, collaboration, planning around potential program synergies that we talked about earlier, coordinate all the campus infrastructure issues, and also coordinate the ongoing projects that are happening. The big one, of course, is the renovation of the M&O wings. And then I'm going to ask Ann Romero to step up for the next slide.
Good evening, Commissioners. My name is Ann Romero. I'm a Senior Project Manager at the Mayor's Office of Housing and Community Development. So this next slide is just the summary of what the roles and responsibilities of the Mayor's Office of Housing in collaboration for this development. And so that is that we are the lender, as you know, and that we also intend to provide certain rental subsidies that can make the housing more deeply affordable. We will also issue the affordable housing revenue bonds for the construction loan for this project. If we move forward with the jurisdictional transfer, we will accept the site under this jurisdictional transfer so that we can do a long-term ground lease with Mercy Housing's limited partnership. We will monitor and oversee this project through pre-development, construction, and operations. We would be the ground lessor, and we will cover our own staff costs. So that is all detailed in the draft MOU. Next, I would just like to briefly outline Mercy's role as developer. So obviously, they would be responsible for all of the pre-development expenses. They would initiate, after MoCD and DPH and Laguna Honda approval of what the parcel map is, the subdivision of the parcel. They would be the ground lessee. They would do the coordination around the how the project might impact the campus infrastructure and hospital logistics. And then they would collaborate and plan around with Laguna Honda Hospital and DPH around possible synergies between the two programs. Finally, they would be the housing operator and the service provider. So that is also outlined. Now I'll call up Sharon Kristen to review the parcel map again with you and the next items. Thank you.
Good evening, commissioners and Mark. Yeah, so I think most of you have seen this map before. It's essentially our site plan, but then it tries to delineate the actual parcel area. So I'm going to try to use this little red dot, which doesn't work. So you might have the presentations in color. So the outer blue dotted line is essentially the parcel subdivision from the larger Laguna Honda to the site that will be used for the affordable senior housing. And we can do that. The next slide might show that a little bit more clearly. Or one of the exhibits in the MOU showed that a little bit more clearly. The other areas that are designated here are areas that we've talked about as being construction easement areas. And so those are construction easements because they will not be owned by the senior housing owner. They will continue to be owned and part of the Laguna Honda parcel, but they are areas that Mercy, using the general contractor that will build the affordable housing building, will do some construction improvements on to basically mitigate the impact that we're having on the hospital. For example, on the upper right-hand side, that red area, right along there is the exit path now from the east wing. So we need to recreate that exit path. The blue area is some landscaping along the Serenity Garden that we're going to build to basically screen the Serenity Garden. The pathway that staff use that from the eastern part, the northern part of the campus down to the front entry will be on our site, but the landscaping is just to mitigate that sort of impacting that area. And then to the left-hand side of the screen, which is again shown in red, that construction easement area is basically to rebuild a sidewalk. Thank you, Mark, right along there, which that area will be likely impacted as part of the construction. So next slide. The draft schedule for the remaining part of this year is we're primarily going to be working on the design, entitlements, and the parcel subdivision process. We'll basically submit the parcel subdivision probably this month, but it'll take probably the remaining part of the year for that to be reviewed and approved by DPW. We'll continue to do community outreach. We'll continue to do JCC and any health commission updates that are requested. And we will all of that will culminate to construction start likely at the end of 2027. We'll apply for financing probably spring of 2027, close on all that financing at the end of the year, and hopefully start construction at the end of 27, beginning of 28. It'll take about 20 months to build a building of this size, so we expect to finish construction in about fall of 2029. And then we'll likely have residential occupancy at the beginning of 2030. And we'll also start the tenant improvements for the Early Childhood Education Center in 2030. Those would only start after we finish residential construction. So next slide. This is the construction logistics plan, really just an outline of what is included. We've reviewed this construction logistics plan with Laguna Honda staff. Basically, the plan identifies the impacts and what accessing the site area, how the site will be accessed by contractors in different phases. So this slide is basically showing the truck route along the Laguna Honda driveway up to the site. They'll show the location of where the contractor will basically have their construction materials, lay down space, and their trailer. And the different phases are generally the grading and ground improvements, concrete placement, and then framing and finishes. So those are different phases of the plan that are all included in that exhibit. Next slide, please. And this was the feedback that we got from the Sequoia Living staff that we met with regarding Woodside Gardens and the transportation, how residents at that building access transportation. So again, Woodside Gardens is at 255 Woodside Ave. It's the senior affordable housing, senior and younger disabled affordable housing that's right adjacent to Laguna Honda. The staff there said they're likely, the residents there mostly access transit on that bus stop that's right in front of the building. Residents also use paratransit and the SFMTA Essential Trip Card. There is some element of parking within the building that residents can use. And then the property management staff have some element of funding in their operating budget to assist residents with emergency transportation. So this is a little bit different from our project and our site, because again, our site does not have a bus stop immediately adjacent to it. So we really see that the difference here is that that separation, if you will, from a bus stop to the front entry of the senior affordable housing project is what residents are going to need some transportation assistance with. And so we are going to continue to work with Laguna Honda staff about how we mitigate and work towards addressing that. Next slide, please. This is our schedule for future JCC updates. We'll bring next month an updated MOU based on your feedback. I think we'll also discuss the jurisdictional transfer. And then in April, we're hoping to go to the Full Health Commission to get their feedback on just the overall project and then the MOU and jurisdictional transfer. Next slide. And I think this is just going over what the exhibits to this presentation were.
Thank you, Sharon and Ann. Is there public comment?
There is.
Wait, I think Dr. Palmer has her hand.
Yes.
So there are going to be 158 units for people who are elderly and or disabled. And what I see is a very small community room and a very small senior center with no communication between them. So there will be not enough space for people to eat together. We don't know who's going to make the food or where it's going to come from. And there certainly will not be an adult day health center. So the combined community room, senior center, and lobby is smaller than the whole daycare, children's daycare. And I'm not minimizing the need of children's daycare, but we don't want people living in these very small apartments without a way to gather. And we want to have, if possible, services for the senior community. And I just don't see this happening in this very expensive project. Also, there's still no idea about transportation. no idea about how people who are more disabled, who need more services, will get them. And so I think it's a boondoggle, and I think it's a really expensive boondoggle. And I think the money might be better spent on smaller sites scattered throughout the city in a board and care or a deeply affordable subsidized housing model. This is very worrisome, and frankly, I'm kind of sorry that Norman Yee ever pushed it on all of us. But maybe you could help answer some of these questions about space for seniors to gather and their visitors. Thank you.
Thank you. Is there any other public comment in the room on this item? I don't see anyone. I do know that we have somebody remotely. Okay, Mr. Minette Shaw, I'm unmuting you. The slide is now showing.
Comparing
Okay, you've got 3 minutes, Mr. Minette Shaw.
All right, thank you, Mr. Morowitz. Here I go.
As my overhead chart shows, comparing the tiny amount of space for the senior center for serving noon meals for ADHD-style programming for people living off campus, and the small community room, ostensibly for use by the 159 residents of the housing project, pales in comparison to the 6,000 square feet allocated for childcare of 50 toddlers. It's clear this project is not about providing housing for seniors. Why hasn't a transportation plan been developed yet to get residents and visitors up the steep terrain from the Forest Hill Muni Station this late in the process? I agree with Dr. Palmer that the lack of a true adult day health center and functional community space for elder and disabled residents and their visitors, as well the lack of advanced planning for both accessible transportation and walkability/wheelchair paths, both around the facility and in the outdoor spaces within it, for frail people and those who want to visit them, indicates a lack of care and concern for the population this project purports to serve. The Health Commission should end this project now, since it has been stuck in the planning process since Mercy Housing was awarded the contract 6 years ago, and because it may not open for occupancy for a decade after the 2019 bond measure was passed.
I want to add, you commissioners have discussed in the past that there's no neighborhood serving retail, the terrain is too steep, and it's space better served or utilized for additional skilled nursing facility beds in San Francisco to stop the massive out-of-county patient discharges. And you really, really need to pull the plug on this tentative agreement you have. You should end this now and reallocate the $50 million pre-development money to another project that could get built much sooner than the opening of this project sometime after the year 2029. You are not going to open this building before then, and you have wasted too much time with this pot of money. Pull the plug on it now. Thank you.
Right, that ends public comment.
Thank you. Are there any additional questions or comments? Yes, Commissioner Green.
Yes, can you tell us again how many children you expect in the daycare center?
Yeah, sure. The daycare center is being sized for 50 children, 0 to 3.
And are there stipulations about how many square feet are necessary per child, both in the
Yes.
day? And what
Yeah.
are they?
Oh, I would have to bring that back to you because I'm not a childcare architect. But it's like one kid for 40 square feet or something like that. And then it's not just the classroom space, it's also administrative space. There's got to be space for the folks that actually run the program office space. So there's parameters and requirements for interior space as well as exterior space, but I can bring that back to you.
Yeah,
I'm sorry that I don't have that memorized.
I'm struggling with the size of the daycare center because, you know, what I could see online is it's 35 square feet indoors and 75 square feet outdoors. And if you look at that math, you need 3,750 square feet outdoors and you've got 6,400. You need 1,750 indoors and you have 6,000. And I think the concerns about having enough space for seniors that are living on the campus is real. And this doesn't seem like enough. I mean, I know there are other comments on this drawing, but I'm very concerned that we have an outsized focus on daycare here when, you know, if this was done, you know, according to ratios, you could get 85 children there. But it seems like a lot of square footage on that side and not enough on the other. And I don't know about how much space is required for admin for daycare, but I really think this needs to be looked at again. And if there ever are any programs that are outpatient programs that we wanted to institute for seniors, there's absolutely no space for this. You know, I think people are right about, you know, all of us have lived in dorm rooms and think back. I mean, if it weren't for the community rooms, you would have felt like you were in a prison cell. So I really would like to see that revisited and a little more creative thinking on that side. And again, I think, you know, we would also like to understand more detail about the transportation issue, because I mean, you know, we drive up to Laguna and you can't even, all those driveways are so steep that, you know, it's bad for people who are, you know, completely competent in being able to walk and so forth. So it would be helpful to have both of those, and also to get a little more information about the logic behind the 6,000 square feet and why so much is necessary in light of the size of the community, the senior center and the community room.
Okay, definitely. We can definitely bring that back, that detail.
Yes. Commissioner Chow.
Just staying with the floor plan, and Mr. Monaco certainly helped blow up the picture so I can see much better. I share the same concern about the disproportion here that President Green spoke about. In terms of if this is supposed to be for not just affordable housing, but also working with the population Laguna generally does, or outreach to our adults who are in need. This seems to be a very large daycare center. And I think we need to understand the absolute minimums that are really required, and maybe we don't have space for 50 toddlers. Maybe we have space for 25 instead, and cut the number down and allow more space, because certainly the senior center looks much smaller, and as was pointed out here, we did talk about the community and senior center perhaps being larger or being able to be flexible between each other, but there's a big wall there between the two, so it's not really meant to be that way. Obviously, that can be very well solved by, I guess, folding doors or something, or whatever you put in that are legal. But again, even that amount of space devoted to your community and the senior center is really shrunk into a very small area that does look like it might just serve meals and not do much more, which would be very unfortunate, I think, for what we're all hoping for. I also see there's a very big bike room, and I'm not sure how many people could ride bikes up that hill, unless you were part of the Olympics or something. Even the roadways, zigzag. So I'm not sure that that is also appropriate use. I do find that a question that was on the diagram that was presented by the public indicates that there are both health services and home health. But what is the home health? Actually, I didn't really understand that there was going to be any home health services. How do we distinguish between and why do we have the two? Perhaps somebody could tell us today why that might be. In regards to the MOU, I'd like to understand better the proposal and from DPH, whether it feels that actually that idea that they would set aside so many percent for Laguna residents that qualify, providing that the city is able to provide a subsidy. And I'd like to hear a little more about what that really means, and does the city really feel that they can actually do that, especially in light of the budget issues that we are going to have for the next several years. And so it's otherwise hard to try to understand. I think the concern that I think President Green has expressed now that we're looking at this, that there's it's just kind of out of proportion. And I wonder if we can do anything that would add to more senior outpatient type services that could be flexed with the community or senior center room. Whether we could cut down the daycare and with less capacity and devote more, maybe if you were able just to put that in half, maybe we could put the senior center over there, which would be about 3 times bigger than it is, at least on the picture here. Those are, I guess, some of the concerns that I have. I'm not sure, it's a little rambling, but you're kind of really all over the place in this whole presentation. It's hard to really speak to the MOU. I'd also like to know that the MOU has been carefully vetted with the CEO at Laguna and meets their needs.
Can you all address any of the concerns about space today, or
Can we first, the specific question about the home health and health services space there that's next to the bike space?
Sure. This goes back to our services plan for the site. So we had proposed that there be an on-site in-home supportive services provider. They work with residents essentially in contract mode. So the offices there are basically for the supervision of the home health aides. And so instead of the resident basically managing their home health aide, a service, usually Homebridge is the service that often provides, this kind of contract mode for in-home support service providers. They would have staff there to supervise those in-home support services. So it would be offices for the supervisors of the home health aides, and then some break rooms for the home health aides. And we are still looking at how we might move some uses around the site to make things a little bit more efficient. We also have been studying internally how many bike parking spaces to provide. We get into this discussion about how many elders often really bike. Some do. Some do. And some people really prefer not to store the bike in their unit. So we're actively evaluating how many bike parking spaces and if there should be a bike room at all. So this is all still being, worked out, literally these kind of amenities. But the amount of community room that we provide is very typical for what we provide in senior affordable housing. I would not say it's smaller. We've been more than happy to take you on tours of senior affordable housing that we operate. We have 30 senior affordable housing communities in San Francisco. And, this kind of space for a community room for this sort of population is very much based on our experience in the last 40 years of providing affordable senior housing. So we don't find that it's truly too small or very cramped. You might find that the senior center is smaller than the childcare center, but these are very different uses with very different space needs. So we're being advised in terms of the size of the senior center by the Department of Aging and Adult Services, who have kind of advised us in terms of what are the needs for a senior center and how much space to provide. But we can sort of write down our justification and kind of how things are being revised. And for health services, that's meant to be essentially a clinic for wellness nurses to be on site to work with residents around their health services. So it's really just an exam room and an office. It's not a large space. So we can, kind of write that down and kind of, and we're more than happy to engage again with DCYF and LIF in terms of the size of the Early Childhood Education Center.
Yes, President Green.
Yes, it would be great to get some follow-up on how this community room size has kind of evolved, because we have a unique population potentially on this campus that might be more disabled than what you might find at other senior living spaces. And you've got this huge hill. I mean, it really is Castle on the Hill. And I think we have to take that into consideration. I mean, if, for example, this Woodside Gardens is right on public transportation. So people may be really more confined on a Laguna project than they would be in some of the other senior projects around town that, I've seen a lot of them. You can practically walk to shopping from some of them. So it would be very helpful if you could give us some information about other senior centers you have that have are projected to have a similar demographic, but also a similar geography.
Yeah, I think we're at the point also where we really would appreciate a more detailed description of all of the different spaces and how they might interact with each other, in addition to some of the justification that you have that you've used to space all of the different spaces, and the comparison and contrast, if any, with similar type spaces that have been advised by bodies that are, I guess, more experienced than us around some of the uses of this space. And then again, maybe Mark or somebody from Laguna Honda or DPH that's representing the interests, that we're expressing here as the commission can also sort of speak to that, to sort of just make sure that, again, that the issues and concerns that are being raised by at least this committee are adequately being incorporated into the kinds of discussions that the biweekly, I think it is, committee that is addressing, and particularly given that we're going to be going to the full commission in a couple of months. And we want to really make sure that we are prepared for the kinds of things that might come up at the full commission with possibly a larger public that have not been party to the year-long presentations and updates that we have been party to. And again, we appreciate your partnership and the responses to it. But again, it's always the devil is in the details, and the concerns that I think that we've expressed on this committee in terms of the seeming disproportionate spacing of the needs that we're representing in terms of the seniors and that population, and those of the child care center, I think, are sort of more germane. So would appreciate that type of detail coming up.
I'm wondering if maybe Mr. Primo can tell us also that the MOU really satisfies both Laguna's leadership and your liaison with this project folks, which in this case is the mayor's office and the developer.
Well, one bump we did hit, to be completely transparent, is we had a very key person in the city attorney's office who represented DPH's interests, sort of abruptly left. So we took some time to get someone to actually replace him. That's been done, and we're just starting to get a lot of synergies between all three city attorneys. I mean, two city attorneys and then Mercy's attorney. And we debated whether we should put the draft MOU in this meeting, and we just decided, yeah, let's just put it out there. But there is a lot of work to be done on this. There's a lot of work to be done in terms of some of the legal reviews and steps that the city has to make sure that it follows. If we do go down that path of a jurisdictional transfer, and then how does the site revert back? Sometimes the city attorneys are talking about a much speedier, automatic reversion back. And so they're studying those legal steps to make sure that we don't stumble when we're at the Board of Supervisors or at other reviews. So we are working together very closely, and maybe we prematurely put it out there, but we're doing it in the face of being transparent and giving you guys a chance to look at everything earlier rather than later.
Well, I'm glad you put it into context, because otherwise it's, and that's really very important, because I think, I would assume at the next meeting, you're going to have a more refined version. I would like to hear from our CEO, in regards to, this arrangement, that we're talking about in terms of a city subsidy for, patients that might move from Laguna.
Commissioner Chow, would you mind repeating your question if you don't mind, please?
Well, in the draft MOU, it says that there may be a set aside, if I'm reading it correctly, of so many beds, and I think there was a percent put in there, which I assume you've all felt was reasonable. Providing the city was able to find the subsidy that would then make this happen. And I'm wondering what that really looks like from Laguna side in terms of, you could also ask that they accept these patients and get the subsidy from somewhere else. But this is saying DPH will subsidize this.
So we actually are in the process of reviewing this MOU ourselves as well. We received it, I believe, on Thursday, and we will be engaging with and providing our feedback. We did do a preliminary review. Benito, who's on our team, who actually really goes through these documents with us as a team. So we will be engaging and providing the feedback on this draft MOU. So this work will continue. As far as subsidy, I think that's a DPH conversation that we will bring up if there is funding. And I don't know if Roland, you have anything to add? I mean, currently I know there's no funding set aside for these beds. So that's a conversation that we'll continue to have. How do, where does this funding come from, and are there other mechanisms to be able to support Laguna Honda residents being able to move into these spaces without maybe having subsidy to hold those beds?
Right, because it seems to me that when, if patients were to leave Laguna like they are now, there is no subsidy for us, or maybe there is some sort in going to, no, Roland says no. So I'm not sure why all of a sudden we would be subsidizing rather than whoever normally would be subsidizing to pay for this. But I think on the next iteration, it would be nice that that since you just got it also on Thursday, that having worked it out, you also bring up the points in which DPH has certain obligations, then you feel comfortable that these are, and Mr. Primo could do that too. But I think from our side, we'd like to hear and understand and make sure that the city really feels, our department really feels that they are comfortable, because this is your chance for us to help make sure that what DPH feels they need to have here is in the contracts.
Absolutely.
Okay, thank you.
And I think, given that the members of the JCC have just received also the draft MOU, and we appreciate the transparency and the early heads up, on it, that we'll probably need a little bit more time also to raise any issues in addition to the one that Commissioner Chow has raised, and have those addressed. Again, we're really trying to get this to the point where by the time we get to the full commission, all of the issues that we at least are vetting on behalf of the commission and the public and the interests that we represent can be hashed out as much as possible. And so to the extent that there is some time between now and the next meeting, maybe we can bring, again, through this mark to that mark, representing DPH and the JCC's interests, or at least the concerns that have been expressed in the questions. But thank you, Deltar, for also addressing that.
Would you like me to make one more clarification on the subsidies, please? So we've all been working to try to identify the subsidies for this 25% of units because it's a very logical way that we could create synergies and would be of tremendous benefit to Laguna Honda Hospital. And we also know that the city's budget situation is very difficult right now. So the way that it's worded in the memorandum of understanding is that it's MoCD and DPH would work together because Mercy will also be looking for subsidies, but there's no obvious subsidy that would apply for this particular set aside from Laguna Honda Hospital. And we're looking at the 2029-30 fiscal year. So I believe that the Mayor's Office of Housing's director and the DPH director have discussed this. And what are the strategies to find, ideally city funds outside of the DPH budget to support these units? Because from a policy perspective, it's very important. So MoCD is also very active in this endeavor, but it would not be until the 2029-30 fiscal year. In addition, MoCD is continuing to look at other subsidies for the other units to be as deeply affordable as possible. So I just wanted to share that MoCD is also active in this discussion.
Appreciate that. Thank you, Ann.
Thank you for all your feedback.
Okay, great. And it's seemingly clear that the majority of the questions really have to do with a lot of the other space uses. And there may be some additional questions on the housing itself. But I think as you have seen and heard that the detail around the space requirements for all of the different things that are happening on this campus, in addition to any questions that might be around the units themselves. Really appreciate as much detail as we can get, and the sort of the linkages and the flow of things on the campus. Appreciate that. Okay.
Should we move on to the next item?
Yeah.
All right, thank you again. We can move on to item 7, the hiring and vacancy report. And I believe Anna is going to be doing that remotely.
Hi, thank you. Good evening, commissioners. My name is Anna Horrocks. I'm a principal HR analyst with DPH Human Resources, and I will be presenting the Laguna Honda vacancy rate, new hires, and separations report for February 2026 on behalf of Erica Thorson, the Hiring and Selection Director. As of February 2026, the Laguna Honda vacancy rate stands at negative 0.94% with an attrition savings of 9.4%. In January, we hired a total of 28 employees, 18 of whom were new hires, 9 transfers, 1 rehire, and 1 2320 RN. The RN vacancy rate with attrition is negative 1.82% with 0 vacant FTE, keeping in mind that the RN vacancy rate and FTE are calculated with attrition savings of 4.76% and 9.42 FTE. In January, we saw 1 total separation at Laguna Honda, which was a retirement. Thank you.
Thank you. Is there public comment?
Is there any public comment in the room? I don't see any, and there's no hand.
Okay, great. Any questions? Yes, Person Green.
Well, thank you for the report. One of the things that I think we're a little bit curious about is there's some vacancies of positions that really are important, like various managerial positions that, the leadership roles really are so critical to moving Laguna forward. And so I wonder if there's any way in the future we can kind of get more details on those positions that leadership feels are critical. I mean, we know about the Dons, of course, but I'm curious to know about, charge nurses and we talked about the committee for nursing, which I think is wonderful. But if you have many, many vacancies in your charge positions and your CNA positions and so forth, that gives us a feel for the challenges you might face in trying to move initiatives along and develop even better ones. So if we could find out something that's more of a trend line, I mean, I apologize. I know I've been told before manager 6, manager 5. I still can't remember what those are. But you see the word manager and you start and even though it's the number of nurses, but what about the charge nurses? I mean, what about the nurse managers? Because that stability is what we were lacking in the past. And what I think is so important, you have wonderful ideas, but you really need these people to operationalize them. So if the reports in the future at some point, and maybe it doesn't need to be in the vacancy and hiring component, but if you can give us more detail about that, it'll really help us understand, how your successes are achieved and what barriers you might be facing as you try to accomplish some of these things.
Yeah, and that might be either as part of the executive team report, a separate agenda item within that report, or within this hiring and vacancy report, whichever is most appropriate given the data and the listing of those positions. And I think just to sort of a slight clarification on that is a lot of these are coded, but they don't have titles necessarily attached to them. And so it's hard to then determine whether they are a critical piece of the puzzle at any given time, given the role that they play at Laguna versus what they're coded as in a HR listing. Okay. Right.
President Green, can I ask you a clarifying question? Because I'll be the person who will help interpret this. When you talk about trend lines, I hear what you're talking about with the titles and understanding priorities, but how would a trend line work in this regard?
Well, I guess what I'm really wanting to know is, as initiatives are trying to move forward, where are the holes in terms of, I mean, it's confusing because there's some nurses that go to a higher position and it isn't reflected in the hiring and firing necessarily. So it's like, what are the critical positions and how many of them are open? How is it fluctuating? I mean, do you suddenly have, a number of charge nurses that, there's a lack of charge nurses, or, the nurse managers are out on, we have a lot of people over time that have been out on leave, for example, and it would be very helpful to understand what you're facing in any given window of time in terms of not just your dons and your people, the administrative leadership, but really the patient care leadership and in terms of the charge nurses, the nurse managers, and any other managerial positions below what we see here at each meeting.
Sure. And then you didn't say this, but meeting to meeting then to help fill in those blanks, that's what the trend line, or so it sounds like you're looking for a story that you can continue, whatever that can be, because we'll have to come up with some creative way to do that. But thank you.
Thank you.
Okay. It's okay to move on, commissioners? All right. Thank you, Anna. We can move on to item 8, the regulatory affairs report.
Good evening, Commissioners. Nazanin Zahir, Chief Quality Officer on behalf of Geraldine Mariano, Director of Regulatory Affairs. During the month of January, Laguna Honda submitted a total of 12 facility reported incidences to CDPH, and we received 4 anonymous complaints from CDPH. CDPH has not started their investigation into the 12 fries that were reported in January. One site visit did occur in January. CDPH investigated 5 anonymous complaints related to staffing, nursing services, and quality of care. The preliminary outcome was no deficiencies for all items. At the time of this report, there was still pending document review, but we did have a site visit in February, and she closed out all those and confirmed no deficiency for those anonymous complaints. A telephone request for 1 anonymous complaint was done in December with document request and was provided timely. Then CDPH administratively closed that anonymous complaint. However, when they visited us again in January, They reopened and reclosed with no deficiencies. So just a little back and forth there. At the time of this report, we had 94 cases open with CDPH. Happy to answer any questions.
Is there any public comment in the room? There's no hand, so there's no public comment.
Okay, thank you, Naz. Any questions on the report? Okay.
Just making sure.
Oh, yes. Dr. Chow.
Well, I actually appreciated the response because I was asking the lagging of closing it. And it says that you said prior to our annual survey and during our annual survey, when is that?
We anticipate it to be in April. That will be our 12 months from our last. So usually common practices, they'll come on site before and they'll maybe review about 30 cases to close out. And then when they come on site during the survey, they generally also do about another 30 to 40 cases. So it won't be all 94, but we anticipate a good chunk to be done.
Fine, thank you.
Move
All
on.
right, thank you. We can move on to item 9, the policies.
Okay, presenting on behalf of Carmen Trin, Director of Performance Improvement. The facility is presenting 2 policies for your review and consideration for approval at the Health Commission. 1 facility policy recommended for revision and 1 departmental policy recommended for revision.
Thank you. Public comment?
No public comment. One
Okay.
time.
Any
Move
com-
approval.
Okay.
That is a recommendation to the commission.
Okay.
Second.
All those in favor?
Aye.
Thank you.
Thank you so
Thank you.
much. Now we're at a consideration of a closed session.
Is there a motion for closed session?
So moved.
Second?
Okay,
Any
public
public
comment?
comment on this item? No public comment.
Okay, all those in favor?
Aye.
All right, great. Give us a minute or two to close this down. Those of you who are watching, you'll not be able to see or hear us while the commissioners are in closed session, but we will be back, and you're welcome to wait for us so you can see it on the video. Thank you. All right, commissioners, you are correct. Oh, we're back in open session doing, yeah, it's already happening. Can we? Okay. We can figure that out later, y'all. But commissioners, in closed session, you approve the credentials report and the PIPS minutes. Please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
All those in favor?
Aye.
And then please consider a motion for adjournment.
Move to adjourn.
Second?
Okay, all those in favor?
Aye.
Aye.
Thank you, everyone.